Hello, PsyQ community, and welcome to today's virtual learning event, Viruses, Vaccines, and Long-Term Consequences, a panel perspective, part 3 in our 3-part series. In case you missed the previous discussion in this series, you can access those at any time on the PsyQ website and check out the updates provided by Dr. Gary Pattee, where he shared insights with me on part 1, Viruses, Vaccines, and Long-Term Consequences, an update on SARS-CoV-2, as well as setting some of the records straight with colleague Jacqueline Canning in part 2, Viruses, Vaccines, and Long-Term Consequences, Mythbusters edition. We took a deeper dive in parts 1 and 2 to focus on the science, the statistics, and the emerging evidence related to the coronavirus pandemic. Now it's time to provide perspectives from a more person-centric or humanistic viewpoint. So today, we're very excited to be joined by a phenomenal group of experts to extend the conversation on viruses, vaccines, and long-term consequences and the impact of the COVID pandemic with this riveting panel discussion. So thank you for joining us. I'm Rachel Self, Clinical and Scientific Director for Otsuka's Neuroscience Field Medical Affairs team. I will serve as today's moderator for the discussion featuring an esteemed panel of individuals that I have the great pleasure to introduce you to you all now. Of course, we have brought back by popular demand, Dr. Gary Pattee, clinical neurologist for Neurology Associates, as well as assistant professor and clinical instructor for the Department of Neurology and co-medical director for the Muscular Dystrophy Association Clinic within the University of Nebraska Medical Center. Thank you for joining us today, Dr. Pattee.
Thank you, Rachel.
Joining Dr. Pattee and I, we have Dr. Gaurava Agarwal, one of our PsyQ Major Depressive Disorder Section Advisors, Associate Professor in the Department of Psychiatry and the Behavioral Sciences, as well as the Director of Physician Wellbeing for Northwestern's Medicine's Medical Group. Thank you so much, Dr. Agarwal, for joining us today.
It's always great to be with you, Rachel. Thank you.
We also have with us today Kathy Day, PsyQ Patient and Caregiver Section Advisor, as well as a caregiver and mental health advocate in Sacramento, California. Thank you, Kathy, for taking time to spend with us today.
I'm glad to be here, Rachel. Look forward to this.
And finally, last but not least, we have Dr. Mojgan Makki, child, adolescent, and adult psychiatrist, psychiatric school consultant for multiple locations in the Chicagoland area, and distinguished fellow for the American Academy of Child and Adolescent Psychiatry, or ACAP. Thank you so much, Dr. Makki, for joining us.
Thank you, Rachel.
Today's program is paid for by Otsuka Pharmaceutical and Commercialization, as well as Lumbeck LLC. Our speakers are employees and/or paid consultants for Otsuka. So without further ado, let's go ahead and dive into today's discussion. Throughout our work together over the last nearly 2 years or so, Dr. Pattee and I have had some very intriguing discussions about SARS-CoV-2, some of the vaccine development happenings, as well as inflammation, neurological consequences, and much, much more. One of the questions that Gary would often ask was, what do your psychiatric colleagues have to say about this pandemic and its impact on behavioral health? So to help address this question, we will get started today by hearing Dr. Agarwal as he helps lay the foundation for our audience on the emotional phases of a disaster, how our stress levels may have been and continue to be influenced by this COVID world that we now live in. G, could you cover some of this for us now?
Well, thank you everyone for being here today. I'd like to go over this emotional phases of disaster response slide. I think for me, throughout, I guess, almost 20 months now, this slide has been something that I kind of keep in the forefront of my head because, I think for all of us, this idea of uncertainty, what should we expect, is really one of the core sources of anxiety. And so this slide to me has been something that helps me at least have some idea of what are the types of things I might expect from myself, my colleagues, and what are the sorts of emotions we need to be prepared for and be looking out for. And so this is the idea that after a disaster, people go through several different emotional phases. The first part of the disaster, especially in my world, trying to help healthcare providers, you were in this initial heroic and honeymoon phase where everyone came together, There was a lot of cohesion within the community. We had a shared purpose, a singular goal of defeating this virus. And then over time, as the model predicts, we began to see us move towards that disillusionment phase, where some of that emotional heroism and that cohesion started to fray a little bit. And you saw people struggling with exhaustion as they came out of that initial adrenaline rush and were really trying to kind of make it through that period. I think then we were on our way to seeing a little bit of light at the end of the tunnel. We saw the vaccines rolled out. We saw case numbers drop. We saw admissions to the hospital start to drop, and people were really starting to believe that, hey, you know what? I think we're coming out of this. And that is typical of when we begin this journey to reconstruction. And I think that word journey is really important. That you slowly build back to this new normal, this new beginning, as you can see in the slide. That process can be facilitated by really working through grief. That's the singular task of that reconstruction period as you create a new beginning. But as you all know, and of course the virus has affected different parts of the country in different ways. In many parts of the country, including our own, over the last several months, we were experiencing setback. And I think for a lot of people that was surprising and disappointing, and certainly was for me as well. But I do think and take some sort of solace in the fact that it's a normal part of disaster recovery, is that setback is built into the model and not uncommon part of what happens coming out of these disasters. I don't mean to take away any sense of how impactful setback can be for folks. I think what you're seeing is a lot of people, the setback can be very triggering. It can cause people to kind of relive that trauma that they had of lockdowns, masks, or the hospital is going to fill back up. It's almost like this reliving of a kind of a traumatic experience. It can lead to a lot of anger, a lot of frustration, and continuing with some of those emotions around exhaustion, etc. And so our job now is to really continue to help provide support to people as we go through setback. I think one of the major errors we make is that while we go through setback, we don't provide the types of resources we did on the front end, and we really expect people to kind of manage the setback while also kind of continuing on with their regular work, and that can be very problematic for some folks. And where this continues to be applicable as we think about those emotional phases is none of us experience stress in a vacuum. The stress that we feel can really be a function of the things that we're dealing with, but also what's going on around us and how are the people that we love and care about doing. And so as we think about setback, you can see how impactful that is to other people, and we can't help but take some of that on ourselves. And so for us, I think it is really an important time to bring back some of those models that we really were socializing at the beginning of the pandemic. And one of the most important ones for us is the stress continuum model. And the reason this model is really important is it really helps increase the level of self-awareness about how am I doing, where am I at for my stress levels, but it also helps improve peer awareness, making sure that we're all looking out for each other. And when I see some of the people in my life acting a certain way, what does that mean? What does that tell me about what color they may be right now, and what do I need to do? Well, what can I do to help them move forward and move back in this green area? This model was really delivered in the first responders group, the military, police, firefighters, to really address some of the stigma that goes around mental illness at times. It provides a destigmatizing language of how you doing right now? Green. Green is far easier for people to say than I'm really struggling right now. And so allowing these colors to be a way that we can talk to each other and have a shared vocabulary has been really effective for us. So thinking about it is green is kind of ready to go, fit, safe, connected. I'd love to say I was hanging out there, but generally a lot of us are hanging on to yellow and trying to hang on to yellow. We're feeling exhausted, we're feeling drained, at times anxious and irritable. And I just like to always tell people that is normal. Going through this and going at 18, 20 months into it, that doesn't mean anything is wrong with you in the sense that there's anything broken or ill. That's a normal human condition of feeling distress during a distressing situation. What we're trying to really do, though, is be mindful of progression into orange, which is injured, feeling hurt, distressed, dysfunctional, out of control, and then certainly staying out of the red or getting the help we need to help move out of the red as quickly as possible, which is really clinical illness and impairment. And with that, I'll turn it back to you, Rachel.
Thank you so much, G. That's really helpful. I know we can all aspire to be green, but that might be aspirational at this point. So I'd like to open it up and ask you, Gary, if you'd share some of your thoughts about the information that G just shared with us, talking about the emotional phases of the disaster, as well as this stress continuum model. How have you seen this at work in your neurology practice, perhaps with patients, colleagues, or even within yourself?
So, I really like Dr. Agarwal's description of these two slides. They really summarize things lovely. I think, Rachel, in answering the question you posed, how it sort of has affected neurological, hospital, collegial relations, I would focus on the disillusionment phase of this response curve. As you can see, that's where the emotional lows are really most prevalent. This is an unprecedented time we're living in. We have never been faced with a virus or an attack mode on our health ever in the last 100 years. And so I think part of the disillusionment is just we don't have a recipe for how to get out of this. When patients first became ill with this disease, and I've mentioned this before, some of the earliest patients in Lincoln to have succumbed were my patients. And it was somewhat shocking at first, and it was trying to get a grasp of what we're dealing with. The disillusionment is, we don't have a recipe. These patients can come in 3, maybe weeks or longer, and there's still no sight as to when they're going to be discharged from the hospital, just because of the multiple complications. And that can be extremely difficult, especially for a lot of the frontline workers. Discussions I've had with ICU nurses in the neuro ICU of the hospitals, it's very hard on them because they're watching these patients slowly worsen, and there's little they can do other than supportive care. I think along this same response curve, it's coming to terms, working through the grief of losing patients and seeing disease that you oftentimes can't have as much of an impact as you would hope. But I think the coming to terms takes time, as this graph describes. But that's through a number of different mechanisms to achieve that. But those were probably the 2 points on this particular slide that stuck out at me, at least with my practice. And this continuum model, I always look at what is it that pushes the stress curve out of control. We talk with our patients about stress. We tell them that we're all faced with daily stressors. And I use a simple analogy. It's like a fire in a fireplace. Stress will be part of our life. It'll keep us warm if we keep it under control. But if it jumps out of that fireplace, it'll burn us. And I think the toxic stressors arrow is the one I'm really focusing on. What leads from green down the wrong pathway? And I think those stressors are what come to mind. And I like, in terms of the orange, the out of control, dysfunctional descriptions, because I think that's what a lot of people feel. And it gets back to some of my earlier comments. I focus on the precedence of other diseases that we can rely on and follow in some kind of a model, which for the most part doesn't exist. Each person can have a different response to this disease. Neurologically, we're seeing a lot of difficulties with a variety of neurologic manifestations. The only real comparative syndrome, I suppose, would be West Nile, which came through the Midwest. We're seeing it now, but it was really pretty bad about 10 or 15 years ago, but nothing to this extreme. It was a little bit more predictive than what we're seeing now. So I think focusing on what leads from toxic stressors to a dysfunctional state is probably what most healthcare providers should be recognizing and attending to.
Thank you so much, Gary. I'm curious to see, Dr. Makki, what are your thoughts about this information?
Yeah, I love this model, the Continuum model, and one that we are very familiar with in child psychiatry, because when you talk about stress, it's difficult for people to understand and to even recognize stress. When we are adults, it becomes even more of a challenge to have conversations about stress with the youth, or even so with a child. So we really use these colors often to talk about, where they are. And as Dr. G mentioned, sometimes people understand and recognize where they are better when we say, are you in the green zone, how far in the yellow zone, or if we are in the red zone. So this model has been really an important clinical way for us to be able to communicate, not just with our patients, our youth and children, but also to help families understand how to assess and how to communicate with us and with their child. So when we talk in our practices, we talk about stress first, normalizing and validating stress. Stress is something that we all go through, and as much as we like to just be living in the green zone, even if we lived in the bubble, we would still go through some biological, psychological, or even social stress within that bubble. So we talk about normalizing and validating stress. Don't run away from it. It's okay to recognize that you have finals, you're going through different situations in life, and that it is normal to feel stress. And we further talk about understanding the zones, and to understand that these zones are bidirectional. And if we go from the left to the right, we are really talking preventive. We're talking measures, how to make sure that we are tolerating, we are managing the stress, and to do everything possible to make sure that we do our best to avoid the orange and the red. And if we go from right to left, we now are talking about recovery. And in child psychiatry, it is both directions are super important to communicate. But when we talk about recovery, it's interesting because we get them into like partial remission, and we get them back in the yellow zone or the orange zone here. And we need to remind them that we still need to think of ways to keep mental health, to keep wellness factors, to still have that good schedule with the sleep, to still try to make sure we avoid risk factors, to make sure that we get to the green, because green is really the best place we want to be. As we know, stress and mental disorders and stress can be accumulative. So we want to try to get everybody to that green zone. One of the factors to kind of bring it a little bit more related to COVID is to emphasize to families and to healthcare providers how to help our patients to process the stress. And as a child psychiatry, it has been, I've spent a lot of time with families to help them understand that we need to process and we need to meet our children and our youth where they are to process. We can't process with them based on what we think and where we are. We need to process based on where they are. Furthermore, we need to take time to process. We need to be patient with processing. We need to recognize that one offspring is perhaps going to have a completely different way of processing stress compared to their other younger or older siblings, or even compared to the parent. And that has been a very, COVID has been an interesting area, because we have a family that one family feels more stress about the virus, one family feels less stress. And we have done quite a lot of work to help them understand to be respectful of each other's ways on how they process and how they see the stress. And I think this is an ongoing conversation that we need to really continue to have, because we are perhaps over the acute parts of the pandemic, but as we are seeing, there is still ongoing stress levels that we see as our youth and children are back to school and they're trying to play catch up with academic accomplishments and social accomplishments. And so the conversation needs to be ongoing to help families understand the different zones and how to make sure that they do always their best to be more protective and stay the best to that green and yellow, but also be comfortable to reach out and get help and resources from schools, from healthcare providers, pediatricians, advocacy groups, and also psychiatrists if they see that their youth is falling into that orange and the red zone.
Thank you so much, Mojgan. And our PsyQ community can hear much more about the impact of COVID on our child and adolescent population with some other offerings that Dr. Makki has provided for us. So those links will be available for you. I'm curious too, Kathy, to hear from your perspective with respect to, your work with patients and caregivers. How have you seen all this playing out? They may not be as familiar with this red, yellow, green type of scenario, but they're definitely feeling it, right? So could you speak to that?
Yeah, they're definitely feeling it. It's interesting. The way I've looked at it through the pandemic is family members of loved ones who have severe mental illness have been dealing with this stress continuum all along, not having the actual model there in front of us. But we've been dealing with stressors that now the general public is dealing with. And so it's just on another level for us. One thing that this slide really was helpful to me on is that my family member was in a locked facility from March of last year when the COVID hit until March of this year. Now he's in an unlocked residential facility. But during his time in the locked facility, they used this model, the colors, to help him manage his symptoms, not regarding COVID, but regarding his psychiatric symptoms. He would feel like he was being murdered. He would feel stressed, and they didn't use the orange, but they used what they called a stoplight system, green, yellow, and red. And it was very helpful to him. So seeing that work for him, the color model, like G was talking about earlier, just identifying not that I feel anxious or anything, but that I feel yellow, is an easier way to communicate how a person is feeling. And I see how this was very beneficial to my family member and the others in the facility he was in. And I'm hoping that this is something that's used throughout. I'm sure it is, at least in locked facilities, but beyond that, maybe not so much. But I can see, what we went through, we being family caregivers in the beginning of this illness, we all went, yeah, well, we've got this because we've done this before for years. But it's really, COVID has taken it to another level. And the stresses that we feel now are completely different. I had a conversation with a mom the other day who, her son is, it's very challenging for her to work with her son now. And because of COVID, she had to work from home. So she was 24/7 with him, whereas before she got a break to go out somewhere. And so that's taken a toll on her mental health as well. Just really, like I keep saying, it's taken us to another level. And that's been a real challenge. So this model is very important for all of us to keep in mind. I'm hoping I get a lot of family members who watch this and learn from this as well, and recognize that we do have what Dr. Makki said, it's bidirectional. Just because we happen to slip into the more severe colors doesn't mean we can't go back to the better colors, the greens and yellows. So for family members, I think we just need to all keep that in mind, that it is bidirectional.
Thank you so much, Kathy. Yeah, and I know, G, I'm curious to see if you have any kind of summarizing thoughts about everything that's been shared, and then hopefully transition us to a more positive note. What can we do in terms of building resilience factors and focusing on that? So could you share some perspectives there?
Sure. I mean, I think everyone's really hit the nail on the head. I think, this idea that it isn't stress that we have to fear. Stress is a part of the normal human condition. It's really how do we turn stress into growth? And in the performance model, we were able to turn stress into growth by using things like rest and recovery. To Kathy's point, I know that's incredibly difficult right now to find that rest and recovery.
Yeah.
But it is still the task that we all have to be proactive and deliberate and intentional about. I think the only thing I would say to Dr. Pattee was, one of the things that I think is a unique potential part of this setback period is there is this sense amongst healthcare providers that there actually is an answer, right? Not necessarily after people have gotten sick, but there is this great frustration around still the difficulty in vaccinating sufficient numbers of people. And that's what I'm seeing is the frustration, anger around that issue, where it feels like we actually do have that answer, but it's not happening quick enough, is leading to some of these problems around civility. That's a big thing that we've been talking a lot about recently, is just how do we bring back civility into our culture, and work with each other, patients, doctors, within physicians, within healthcare providers, just all together really learn how to respect each other's views, and at the same time continue to encourage good health behaviors.
So we'll transition a little bit here and really try to dig in a little bit more about what can we do, some of these positive aspects. So you can see the resilience reservoir on this slide, which is just a way to conceptualize thinking about what drains your tank versus what replenishes it. So I know, G, you do a much more eloquent job talking about this than I do. If you could give us, a super high level snapshot, and then I'd like to hear from everybody some thoughts on resilience.
Yeah, I mean, I think for me, I like visuals, and some parts of math I like. And so, I think this diagram has always helped me do a little bit of quick math with myself, right? And so that the color slide is just an awareness slide, right? For me to go to that next step about seeking out help or utilizing a resource or even feeling like I need to, I have to first know how I'm doing. And so self-awareness is the fundamental building block for any of this to work. But after you recognize, hey, you know what, I'm not at green, and so therefore there is room to improve. And as Dr. Makki said, even at green, you have to keep at it. Otherwise, it won't be long till we move over. The question then is, how do we think about what can I do? And so I know when a patient comes to me, for instance, and someone says, my life is really stressful, I don't feel like I can do anything with that's effective, because life being stressful is too global. We don't know where to start or how to intervene or what things might be of the highest yield. And so that's when we start subcategorizing and diagnosing, if you will, and classifying what are my sources of stress? What are the things that drain me? On this slide, you can see things like loss, triggers for past trauma, sleep deprivation, humiliation, and of course, all of us have numerous things that drain our tank. Our task is to figure out which of those things that are draining our tank can we slow down or eliminate, which of those things are in our circle of control, and which of them are not, right? Because I think what happens a lot of times is we end up focusing in on things like, I can't change this right now, right? I'm out of work, and right now there's things I can't change, or my child is sick, and I can't really change that right now. And we get caught up on those. And then the real issue with that, of course, is that there were things that we could control that we're not owning, and we're not slowing down the draining of our tank. So that's kind of step one. And then step two is to recognize there are going to always be things that drain your tank, that continue to occur. And so we can't just focus in on eliminating stress or slowing down stress. We will always have to be proactive and intentional about refilling our tank if we're going to maintain a tank that is somewhat full. And so again, this is where spending some time thinking about what fills your tank the most, what fills it quickly, what fills your tank that you have control over, and that's different things are true for different people, but always things around psychosocial support, social healthy activities, mentorship, intellectual stimulation, and lots of other things. I think one thing I always like to highlight about this is sometimes people think this is all on me, and I have to be reducing my stress, and I have to be doing things to fill my tank. And certainly we all have accountability to ourselves that we do need to do. But whenever I show this, I always highlight for those in the audience that are leaders that have the ability to influence how other people work, that we as institutions, organizations, companies have a role to play as well in both reducing stress or doing things that increase our tank, if you will. And that can be around appreciation and recognizing the hard work of folks so that, you know, they feel valued and they feel like, hey, you know what, I belong to this community that really cares about what I do. And so these things can be impacted at the individual level, but also at the community, work, and other system levels.
Thank you so much, G, for that. Let's take just a super quick moment to go and hear from each of you. We can start with Gary. We kind of started that round robin, so we'll continue with that. Gary, what are your thoughts about this? Anything that you'd like to share about what you're seeing, either personally or with your patients and your colleagues that you could suggest for helping to replenish our resilience reservoir?
Yeah, I think that Dr. Agarwal's description was excellent. As I look at this, I suppose the question that comes to mind is, what drains our replenishment? In other words, what keeps those replenishing factors from being successful? If you look at each one, and I've been kind of looking at this slide for a while, the psychosocial support within this time that we're living in is significantly affected. Patients who are unemployed, patients who can't meet with family, can't go to church, can't gather with friends for coffee. Any of a number of support units are oftentimes being compromised, yet it's so important to help replenish their reservoir. Same with intellectual stimulation. I haven't been to a medical meeting in over 2 years. They do the online meetings, which are okay, but it's not the same as standing by a poster and talking to somebody about their research and sharing your research and that camaraderie that you get. I think it's important. I think the same with mentorship. There may not be quite as much in my current community, but just collegiality, if nothing else. Meeting with other physicians, and you know, we would have meetings, oftentimes local meetings amongst doctors. That's all pretty much been put on hold. And then social healthy activities. I think the key with exercise and sleep, so important, and can't be emphasized, I think, enough, because we will get through this. There is light at the end of the tunnel. It's just identifying some of the key points, which have already been brought up today, as just markers of hope. I think we'll touch on that a little bit later. All of these, I think, help with this resilience reservoir that this slide highlights.
Yeah, so from perspective of a child psychiatrist, I would say we continue to send the message to families that resilience is individualized. And so one plan that may have worked for a child may not work for their brothers or their sisters, and that there is conversation to have to recognize the strengths and the areas that a child can improve upon. And those strengths and areas of improvement are can be very different, even within a family, from one child to another. So really getting to know the family, getting to know our children and our youth, and spending time with them to get to know them, and to make sure that we also talk about what are some of the factors that bring stress to us, so that we again normalize that we want to hear from you, and that feeling stressed doesn't mean that you're a weak person or that you're not going to be a successful person. So that's more on like the protective measure of it or conversation of it. And of course, as everyone has just mentioned, there is so much importance into structure, sleep hygiene, dedicated time for physical activities, especially during the COVID, where we have been so much stuck at home, staying with our computers. And similarly for the kids, they've been doing online schooling and then socializing on social and gaming platforms. So to really help them carve out the time to go for that 20-40-minute walk and to have a good hygiene, to think of sleep structure and not allow any of those have a negative impact on their health and wellness.
This is, again, something that caregivers of people with severe mental illness have had to deal with for as long as they've been caregivers, basically. But I think we've learned more, and a lot of good has come out of COVID in that, yes, we used to get together for in-person support groups. Now we're doing them online or on Zoom or something like that. And it's not the same as Dr. Pattee mentioned. It's as being able to see someone in person, giving someone a hug if they're having a rough time, but it's a workout around to where we still get that social connection. I think probably the hardest thing that most caregivers had to do is if their loved ones were in residential facilities and not allowed visitors for at least the first year, that was probably the toughest thing for people to deal with. I was only able to see my family member during that time because I am his conservator, and I needed to move him from his location to another location briefly. So I got to see him, but I realized how fortunate I was because so many people didn't get to see them. My cousin couldn't see her father, my uncle, in a facility because he was in a senior facility and couldn't visit. So, you know, a lot of organizations have come up with different types of ways to overcome that social limitation. We're able to visit by Zoom or another platform. We're able to actually, you know, maybe sit outside the window and have a, you know, see them through a window to where we're still socially distanced and still get to see the person and talk with them. But gosh, it's just been hard. So what I do is I recommend to family members that, you know, the replenishing things, the exercise, the proper sleep, the nutrition, and those are things that we can do even if we're stuck at home. We can, on a Zoom meeting, we could do exercises together, mild stretches, something like that. We can find ways around this. And rather than calling it a tank, we've always called it putting your oxygen mask on first. You know, as caregivers, if we don't take care of ourselves first, we can't take care of our loved ones. So, you know, we've been stressing that a lot more. We have some very robust social media support groups too, which haven't been impacted by COVID. We still have the same accessibility there, which is very helpful. But it's just, you know, when it becomes so isolating, that's the challenge. So at least we do have some ways to get around them with phone calls, with social media, with, you know, other options to be able to stay in touch with our family and have that connection, and for them to have connection with other people through social media and video. So I guess that's how we would look at replenishing our tanks after they've been drained by this terrible pandemic. So
Thank you, Kathy. Yeah, thank you. Yeah, I think we've all had to learn how to adapt and find new refreshing ways to hopefully replenish ourselves, or at least find some of those things, you know, to what Gary was saying, that are blocking our replenishing activities. So let's take a moment to talk a little bit more about some of this potential mood impact. So as we transition to the next slide, this information has been covered to some extent in parts 1 and 2, and some of the information that we covered even last year. So I encourage everybody to take a look at that. But let's just really quickly take a few moments to hear your thoughts. And I'll actually kick this off, Mojgan, to you first, since the first bullet point is your area of expertise, talking about some of the mood impact for children and some of those self-report measures that we're continuing to see change. Could you speak a little bit to that for us?
Sure, Rachel. And I think we also discussed some of this at our previous recordings, but we know that even before pandemics, the rates of mental health and suicide had been rising steadily for the past decade. We know that by 2018, suicide was the second leading cause of death in youth ages between 10 to 24 and continues to remain as the second cause. And youth have been through quite a lot of significant level of stress with COVID, and not just the physical health concerns, but also escalating in mental health crisis that we are all facing, and brought in by the physical isolation, by the ongoing uncertainty that we saw in some of those diagrams in the first slide as discussed by Dr. G, and then fear has been a significant factor. In the study that we have here, this is a Chinese study that was completed in China and showed a significant increase in level of anxiety, depression, and stress in primary, secondary, and high school students. And we have gotten similar reports from studies completed in USA, including reports that there's been a 20% increase in ER visits for mental health emergencies related for children. There has even been a significant increase in suspected suicide attempts in adolescent girls in 2020 over the course of the pandemic. Furthermore, there is the other risk is the grief and the loss. We know in United States, we have about over 100,000 youth that have either lost a primary caregiver or a secondary caregiver. And so the impact of that grief is still going to be areas that we should be considered and we should keep an eye on. And we also know there is a disproportionately increase in mental health in children, in colored children, Hispanic families, African American families. So I think we are where we are, and we have done the best that we can to be managing. But for me, it's the conversation about let's keep an eye and let's understand that there is some longitudinal effect of what we have already gone through, and that we need to create innovative strategies and ask for policies to continue to be able to provide that additional support for our youth and children, to increase access to telemedicine, to provide support for schools, and to integrate, to bring primary care physicians into the picture so we can continue to support, monitor, and treat as we continue to go through some of the challenges that is coming up for us.
Thank you so much, Mojgan. Kathy, I'll let you speak quickly, and then we'll kind of transition, hear thoughts from both Gary and G about some of the changes in prescription patterns and things along those lines. But you know, there's some interesting bullet points here, Kathy, that I feel like you could shed some light on from a patient, caregiver, and advocate perspective. You know, particularly this increase in substance use that we've seen, and just kind of the impact on, you know, the spectrum of ages that we see that need care, right? So could you speak a little bit about your perspectives on that?
Well, actually, first I want to address the older adults issue, because I do live in senior housing, and I've experienced that around several people around here who've been so fearful of the illness, of contracting it, and because of that, they've been socially isolating, and it's been really, really difficult. We kind of implemented a little plan of going around and checking on neighbors just to make sure that they're doing okay. My mom has actually been particularly hit hard from it. She has rarely left her apartment since the COVID hit in March of last year. That's when we, I guess, first realized how bad it was getting. And so she's when she does go out of the house, she has severe anxiety. She'll become very agitated. because of isolating so much. So that's been a huge challenge. And I've seen that in some of the other adults who live in the senior housing here. So it's definitely something that is a really hard thing. And just, the best thing I could say is just, if you know you have elderly neighbors around you, go check on them. Just give them a phone call if you have their phone number, knock on their door, wear a mask, bring a mask for them, just to make sure they have one, and just try to keep them engaged socially. As far as the substance use, a lot of people, especially in the early months of COVID, if they were on long-acting injectables, the patients were unable to get those long-acting injectables in many cases because the nurse that was providing the shot didn't want to get that close and administer a shot. So they were instead given oral medications. And we know there's a reason for long-acting injectables. It's because people aren't necessarily going to be compliant to oral medications. And so that did happen. People went off that. So then the self-medicating began because they weren't properly medicated. They forget their pills, with the addition of all the other stress they had. There's a few that I know that their loved ones were doing very well, had jobs, but due to COVID, they lost their jobs. And so that triggered a spiral. One young man ended up in the hospital for 5 months, I think, after that, after having been stable for 9 years. So, and that wasn't due to drugs. It was due to not taking his medications. He no longer had a structure. He lost his self-esteem by losing the job. And it was just, it's just been rough on everyone. So, I certainly understand why they choose to self-medicate. But obviously, if we had better supports in place early on because it did take a while even to get telehealth going to help people. But if we could, learn from this and continue the things that we have learned going forward, like Dr. Makki was saying, we don't need to just do this for COVID and then stop. We need to continue on being able to provide the services that people need where they need them and check on people.
There's a slide that we've reviewed before in one of our prior talks, and I think it's very revealing. Now, I don't have a large psychiatric per se population, but from a science perspective, we wonder the issues of psychiatric disorders, schizophrenia. The third bullet point, within 2 weeks to 12 weeks of COVID, the first instance of psychiatric diagnosis occurs. It actually makes me think back on, as I mentioned earlier, some of the West Nile cases that we saw years back, where they would develop encephalopathic processes, not necessarily, I suppose, psychiatric disorders, but that's always been a concern. We're also just on the side working with a large DNA double-stranded virus now in our lab, and it has been shown to have high titers in patients with schizophrenia and other major psychiatric disorders. So the real question, I suppose, are some of these disorders a consequence of the actual effect of the virus, or is it the psychological potential stress that the whole syndrome has caused people to undergo, and that has had maybe pushed them to a brink of a breakdown, or whatever term we want to use. In terms of the increased prescription rate that you mentioned, Rachel, I suppose in the neurology literature or world, that's not as much of an issue. I think we're seeing more alcohol use. I think we're seeing more patients who want agents to help them sleep. We're seeing that more. We don't have a lot of long-acting injectables like Kathy was referring to, although some of our MS patients are on monthly infusions. And there has been some concern with whether they can come in on a timely basis and get those. So I think it's fascinating. And just to touch on the mood aspect, I think a lot of the mood issues I've seen have been a consequence of lost time, lost wages, lost experiences, not going to graduations. It really has this long-acting effect, and how that impacts with one's psychiatric health, I think can't be ignored.
Thank you so much, Gary. Yeah, it's fascinating, and through our discussions and anybody who knows, definitely, I think there's a very strong inflammation component that is going to have a double whammy effect for both from a virus perspective as well as the impact just on our daily lives and some of that loss. And I know, G, you have a lot of experience, obviously, prior to the pandemic, dealing with professionals and their experience of burnout and just extremely stressful situations, which has taken on a whole heightened capacity during this pandemic. Could you share some thoughts on this information?
Yeah, I think especially around this bidirectional impact, I think I'm reminded of how important our audience is going to be in the aftermath, and they need to be, because whether we're talking about long COVID specifically, or we're talking about our patients with mental illness, sometimes I think this idea of trying to figure out who is a frontline doc is a mistake, right? And that's not to take away anything from our ICU colleagues or hospitalist colleagues, but if you look around, it is very, very difficult to get into a therapist or psychiatrist's office because the demand is so high right now due to all the factors that you've been hearing about. But I also think that as we begin to understand better this idea of long COVID, one of the best things we will do is to have multidisciplinary teams that are responsible for the rehab of these patients. I don't think we will do a great job if we only are looking at it from a biological or medical lens, or even a neurological lens, or a psychiatric lens. I think all of us coming together will give us the best chance to help these patients resume functioning in their lives, whether it be at work or at home. And so I think our field is going to have a major role to play, and I hope that we're very proactive in that.
Thank you, G. And I have a sneaking suspicion that Kathy has some thoughts on this information as well.
I do, particularly in regards to the information about patients with schizophrenia who are at higher risk, second highest risk for death, actually, from schizophrenia. Excuse me, from COVID or from schizophrenia. But when my family member was in the locked facility, there was not a priority at that point for people with schizophrenia to get the vaccine. So 43 patients in his facility out of a total of 51 contracted COVID last Thanksgiving, right around then. He was one of them. Thankfully, he had a very mild case of it. He doesn't even remember having it, which I'm grateful for. That's a good thing. But now the CDC has put schizophrenia and mood disorders into the list of priorities for the boosters. I'm very grateful to the facility he's in right now, because they've made sure they've gotten the first 2 shots, and just last week they got their boosters as well. So this is good news that science is looking more at these risk conditions. There's plenty of data out there about the risk of people with schizophrenia. So I'm just glad to see that there's more effort put toward getting boosters for them and realizing that they are more at risk. Just wanted to add that.
Yeah. Thank you, Kathy. Yes, I think it's so important, because this is such an emerging area. We're really trying to get a better grasp on what this bidirectional relationship looks like now that we have some pretty confirmatory evidence that it exists. What are all the different facets at work that are kind of underlying some of this? So let's take a little bit of a deeper dive on the next slide for one of the probably big contributing factors, which all of you have touched upon a little bit, in terms of social isolation and loneliness, and sort of preventing us from some of those replenishing resilience efforts that maybe we had access to previously. Mojgan, could you speak just briefly on your experience for this social isolation and loneliness from that pediatric adolescent population perspective?
Sure, Rachel. Yeah, it's to think of what could we consider as, or what can we think of one risk factor or more likely risk factor that could increase the risk of mental disorders in the vulnerable or even, in the general population. And there's been a lot of different conversations about identifying that risk factor. If we have the risk factor, there would be more chances of putting preventive measures for the future. And when we look at all the different changes that has happened with COVID, we see that the social isolation has been one of the major risk factors. But that by itself was not affecting everyone the same. And we saw that some folks managed social isolation or actually felt better with knowing that they don't have to go to school, they don't have to have other interactions, particularly with some of our youth and patients who have anxieties and social anxiety disorders. So digging further in, it appears that it's more the fact of loneliness. And so if we find out that this social isolation has brought loneliness, the feelings of loneliness, then we actually started seeing an increased rate of that kind of orange and then red zone for those patients or clients. And so then the conversation would come back to what can we do about this now that we have identified loneliness as a risk factor? And for clinicians in my practice, I have started asking people, how is your mood? How's the anxiety? But then I also started asking, do you feel lonely? And it has been a new experience for me. And sometimes when they say their mood is okay and their anxiety is low, when I ask the question of loneliness, they actually identify with that easier than they would with stress, anxiety. And so as clinicians, I think it's been an important opening for us to understand, to incorporate the question of loneliness within our clinic systems, and then to encourage and to bring ways that we can be preventive by talking to the families that even with the social isolation, it doesn't have to be emotional isolation. And I like to ask my families to distinguish the difference. There is the physical isolation that like we have when we put our patients on immunocompromised situation, like our youth with mononucleosis that go into the physical isolation. Then there is social isolation, which has been new for all of us through the COVID, but we really need to be attentive to that emotional isolation and to work on that. I want to just reflect that even not just US studies as shown by this really strong study on ACAP, but even in other studies from other countries, the protective factor has been family closeness. Mm-hmm. And parent-child relationship. So the youth that had a stronger relationship and felt more connected to the family had lower risks of anxiety, depression, and stress. So I think those are really two good studies to bring this to our awareness and for us to make sure we bring it into our clinical day-to-day work.
Yeah, thank you so much, Mojgan. I'm curious, Gary, what are your thoughts on this, and particularly, maybe touching upon that piece of technology and how we might be able to utilize that? I know you spoke a little bit earlier about the impact of social isolation and loneliness, but anything to add?
So right now we're seeing patients that otherwise wouldn't be able to be seen through our telehealth mechanisms. I run an MDA clinic. It's a multidisciplinary clinic where we will see patients who can't make it in for a number of reasons, and now we have access to their living rooms. And so I think this actually is going to change things as we go forward. We'll continue to have telehealth visits. We find it difficult for our first encounter, certainly, at least neurologically, to do that on TV, but for follow-up visits, it has been real helpful. It's also gotten away from this, medical isolation a lot of patients have had. They couldn't get in to see their physicians, and this way we can touch bases with them and reach them. And I think the whole concept with physicians, and we've talked about it already today to some extent, but it's a real problem. It can't be overemphasized enough that this loneliness and this isolation and the impact on mood and even suicide within the medical community is a real concern. And so it's a matter of reaching out and finding ways to connect. And you have to be a little creative, but I think that I think we're coming to grips with it now that we've been in this for a year and a half, and I think we're finding ways to better equip ourselves. And I think most importantly, as we see, hopefully, the light at the end of the tunnel coming, that will help prepare us so that should an event like this happen again, we might at least have better strategies to approach it.
Thank you so much. Yeah, those are great points. So we always strive to leave our audience with some sort of silver lining, if at all possible. So let's talk for a moment about reasons that we have to hope. You know, we hope that the light is at the end of the tunnel, and we've talked about some strategies to try to employ now to help improve our self-care. But let's just go around quickly and hear from everyone. You know, what are you seeing as sources of hope right now? Kathy, I'll start with you.
Thank you. What I see as hopeful, and I have since we started using telehealth, I think that, you know, some people have said that telehealth was now an overnight success, even though we've been trying to get it into the mainstream for years and years and years. But now, due to COVID, we've found a way to get it paid for by CMS, and lots more practitioners are using it, and that has made it a lot easier on people. Especially in the people that I work with, there are some whose family members isolate in the bedroom and had been unable to go to a doctor physically. And now that doctor can basically come into their home. And in many ways, the parents really see that as a benefit, because they can, not that they're eavesdropping, but they can overhear. They're more likely to be included in the conversation with the doctor and their loved one because they are right there in their home. It seems like it's a more natural thing for the loved one to have the family member on that call. And I think they're seeing better outcomes due to that, partly because the family member input and partly because more access to the telehealth for the loved one. So to me, that's the biggest takeaway as far as optimism for the future, is that we know how to do that now, so we can just keep doing it for anyone who's isolated. The people in rural communities that don't have a psychiatrist nearby, we can use telehealth for them because we've established now that we can do that. So I think that that for me is the most important takeaway. Positive.
Absolutely. If only we could figure out some way to have, you know, some telehealth arms reach out to give you a hug every once in a while, then we'd be in a much better place.
Yeah, so I actually have been given virtual hugs to my kids, to my patients, because they're so cute and adorable, and they have been so strong through all of this. Some struggled more than others, but they stayed so strong, and everyone, including their families and the schools, have been so impressed with the resilience that they have brought to this. And I think that is one of the strengths from this, that we see our youth managing and putting those masks on and going to classes and being the first ones that would want to get vaccinated, even the ones that struggle with sensory issues, like children on the spectrum of autism. I still have like telemedicine appointments with school where they take me to the classroom through cameras, and I see these really wonderful students with their own sensory struggles, but that they have been able to keep the mask on. So I think that it has brought our attention to be proud of them and be there for them to continue to support them.
Well, you know, Rachel, I think just this whole conversation we've had this afternoon and reviewing some of the key players that patients and caregivers are running into is very important to understand what we're up against so that we can take back control. And I think hope for a lot of people is seeing, how do we overcome this? How do we keep the virus from controlling us, so to speak, in the world that we live in? So everybody wants to know that there's sort of a pathway, and we all have kind of our own unique paths in life, obviously. And in understanding the players involved and then understanding the coping strategies and mechanisms to help overcome is part of that whole hope process. I think one thing we haven't talked too much about is something as simple as a Zoom meeting with other providers, other colleagues, a number of different ways, kind of like we're doing now. So you can kind of connect with people face to face I don't know about the virtual hug. That would be pretty cool. But we've got apps where we can get force vital capacities by how long they hold a note. So there's a lot of really creative activities that have come out of this whole pandemic that we're going to be able to use going forward. But I think there's a lot of reasons to be hopeful, but it all starts with sharing your fears and sharing your concerns, and I think learning more about this particular virus and how we can fight back.
Yeah, I mean, I think for me, in our PsycU community, I think we have made a major dent on stigma that existed around our work. I mean, the stigma around talking about these issues, talking about stress, loneliness, depression. I think this has become much more mainstream over the last 20 months, and clearly stigma was a major problem in terms of our ability to practice at our top of our abilities. And then, you know, for me personally, I study work, and I think that this time has really allowed us and will continue to allow us to think about, you know, what is it that we do for work? Who do we want to work with? When do we work? What do we do for work? And why do we work? And I think all of those are really important questions for us to think about as a society, as individuals. And my personal belief is work plays a major role on our mental health, and mental health plays a major role on how well we do our work. And so we have a really interesting opportunity right now to really explore certain things that I think we took for granted, and that'll be tough, and there'll be some difficulties as we come to grapple with those issues. But I think they're really important discussions that will lead to us to have a better society.
Absolutely. Thank you so much for that. And I agree with you 100%. I feel like everyone has shared today that the growing need for all of those out there who are part of our PsycU community, for us to come together as a network and provide support to those who need it as we continue to navigate through this and really fully understand what the long-term consequences are of this pandemic. So I hope this is helpful. I appreciate everything that each one of you has contributed and all that you're doing for everyone in our community each day. Thank you so much for that. Unfortunately, we are just about out of time, but before we go, my sincerest thanks to Drs. Agarwal, Makki, Pattee, and Kathy for their time and insights today. And of course, thank you to our audience for joining us for Viruses, Vaccines, and Long-Term Consequences, Panel Perspectives, Part 3 in our 3-part virtual learning event series. This was brought to you by PsycU and sponsored by Otsuka and Lumbeck. Please keep doing what you're doing. Thank you so much. We would like to remind everyone that PsycU is now available as an app on your mobile device. So you can please download that, and you can access all your resources in one spot with the app. We'd also like to keep you up to speed and on the go with all things PsycU by following one of our social media platforms. So we have Twitter, LinkedIn, YouTube, podcast channels. We invite you to join the conversation for any future webinars using any of those social media outlets. Tune in for many more learning event series, webinars, podcast interviews, and much more exciting content coming your way soon on PsycU. With that, thank you again so much to this esteemed panel for everything that you've done, and hopefully continue to contribute to our PsycU community and everyone that you touch as well. Have a fabulous rest of your day, and please do your best to stay positive and be well.